So I'm going to move on to introduce our speaker for today. Adreanne Waller is an epidemiologist. That's a real boots-on-the-ground epidemiologist, not an ivory tower epidemiologist. She trained here at the University of Michigan, and she's now, and has been for many years, an epidemiologist with the Washtenaw County Public Health Department, where she works in health promotion and disease prevention for Washtenaw County residents. She's been there for 30 years. Does that sound about right? 30 years with the health department. And her most recent project and most intensive focus right now is the opioid epidemic. And we invited her here to give us a sort of a local, real world view of what's going on with opioids in our area, in our county. I think sometimes we read the newspaper and we do our national studies and average data across the country and think that this is a problem that someone else faces, but it's a problem that we're dealing with every day here in this county. Maybe it's worse in some other areas, but it's pretty bad here. And so we're going to learn about the efforts of the public health community to address this in a real world way here in Washtenaw County.
Good afternoon, and thank you all for coming. I really appreciate being invited. I kind of feel like I'm in an ICU. I have two mics on. I'm expecting some feedback, but I don't know. I sort of want to do a blanket apology, sort of a dog ate my homework sort of apology, but not quite. We had a family emergency this week, and so I haven't had a lot of sleep. I'm not exactly on my game, but hopefully what I will lack in sharpness, I can make up for in my care about what's going on with this epidemic, and my concern and my gratitude that you all are here and interested in the issue. So Dr. Richardson is someone who I've worked with in the past, and I was especially honored to be asked because I consider her one of the most remarkable researchers who has really committed herself to not only doing great research, but really making sure that that research has excellent execution in the community. And in fact, we have a program that Caroline helped us to get started, I'm thinking 20 years ago now, in Chelsea, Manchester, Dexter area, encouraging many of their residents to walk and socialize in very healthy ways. So I really appreciate being invited. So as you may or may not know, the opiate crisis is here in Washtenaw County. And we have, unfortunately, I had many more newspaper articles that I could have included on this slide, but just chose a few of them. So what I would like to talk to you today about is addiction, overdose, and the paradox of many of the issues in the opiate crisis. I found this quote to be very appropriate, and typically it applies to a lot of things, but in particular, this issue. So one of the things I'd like to challenge you with today, as you look at the information that I'm going to share with you, is to think about when we look back at this epidemic in 20 or 30 years, what will we have learned from the epidemic that will make health care, well-being, how we live, how we treat one another differently? And I can think of a lot of different epidemics that I've worked on over the years, including chronic disease, infectious disease, healthcare, delivery, those sort of issues, all of which have taught us many things. We know that more medical care is not always better medical care. We know that more food is not always better food. We know that bigger places to live is not always better for human beings. There's many things that we've learned. And so I'm really hoping that as we go through this information that you can kind of keep in mind, what do you want to look back and say that we've learned? So I'd like to just cover a few different areas. Where are we right now in Washtenaw County regarding the reality of the opiate issue? What are some of the things that I believe have really shaped the forces in this epidemic? And what is really keeping us in a holding pattern, and not just a holding pattern, but things getting worse? And then what are we doing in Washtenaw County to address these issues? And then what do we need more of? So first of all, I really want to just take a moment to acknowledge that I'm going to be sharing a lot of data. These data represent individuals, and individuals in your neighborhoods, your communities, and I suspect many of you have had friends, families, neighbors, maybe even yourself struggle with this issue. And I want to just express my respect and gratitude that we are able to learn from all of this tragedy. A little bit more gratitude. As I said, I'm really grateful that first of all, I'm grateful that the Institute for Health Policy Innovation, Health Care Policy, I think I put that wrong, sorry about that. Health Care Policy Innovation exists. I've been kind of looking at the faculty profiles and the projects that you all are working on, and it's a remarkable effort. And I'm really grateful, especially working for government, where I know that your work can really benefit the local community. I've worked with many of the U of M faculty over the years, including a number of them who are in the department or in the institute. And I've worked with Mishar, I've worked with Dr. Matt Bolton, I've worked with Dr. Richardson, I've worked with Toby Citron, many projects over the years, Dan Kruger, working on lots of different issues. I started out as a general epidemiologist back in the day, and theoretically I'm still a generalist, but this epidemic, as well as suicide, mental health, and childhood trauma have really risen to the top of the public health agenda in my mind. So anyways, I'm really grateful for the work with those faculty members and how they've chosen to contribute to their local community in many ways. I'm also very grateful to the data providers, and I'm going to share a little bit more about that in a moment and who those people are. I'm also very grateful to Washtenaw County government and Washtenaw County Public Health. And I can tell you for sure that not every local public health department allows their epidemiologists to really focus this much on these kind of issues. And so I feel very fortunate that our community, I'm able to do that. And then finally, I really want to give a shout out to the researchers who are brave enough to work on issues that are really focused on community, on mental health and substance use disorders, because as we all know, these are issues that do not follow an academic year. They don't care about grant deadlines. They often move backwards. And so I really applaud you, because I also know that it's often more difficult to do things like get tenure when you're working on these issues for many reasons. So just wanted to mention that. So I just wanted to start with a quote, and if any of you know who said this quote, there's a first aid kit at the back that you get to go home with today. So I'll give you a moment to read this, and anybody just shout out if you know who this is. Some of you closer to my age should know who this is. Anyone? Very good. Want to say it louder? Matt Davis? Matt Davis. So I really appreciate this quote because he's right on cue regarding working with governmental agencies and community, and it's much harder work, and you really have to get up close and personal. And I really thought it set the stage for the kind of information I'd like to share with you today. So first of all, a little bit of an overview about some of the data sources I use for this epidemic. The mortality data is almost exclusively from the Washtenaw County Medical Examiner, who is, I believe, head of the pathology department. I don't know if he's head of, but Dr. Jeff Jensen. He is remarkable. I can tell you I've met a lot of pathologists working on this issue, and I can tell you for sure that not all pathologists really take a prevention approach, a community approach, a concern that Dr. Jensen and his whole staff have really expressed. He keeps us ahead of the curve on this. So I really want to give them their props. The emergency departments in St. Joseph Mercy Hospital, Michigan Medicine, and the institutions share information with me on a monthly basis regarding admissions for opiate overdoses as well as other injuries and poisonings. It's a lot of work that they do giving me that information. The Huron Valley Ambulance, which I believe now has a new name, they provide information regarding all of the runs they do that result in a naloxone administration, which is the overdose reversal drug. And so that's very helpful for us regarding prevention. The MAPS data, Michigan Automated Prescription System, shares information about prescriptions filled in Washtenaw County. Treatment admissions for publicly funded admissions for treatment, substance abuse treatment, is provided by the Community Mental Health Partnership of Southeastern Michigan. I have quite a bit of behavior data regarding Washtenaw County residents. We do basically a behavioral risk factor survey about every 5 years of 3,000 households in Washtenaw County. I use a lot of that information in helping to shape what part of what you'll see. Arrest data comes from uniform crime reports at the state level. Great database for those of you who are interested in, it's right online. And the most important aspect of this surveillance system is what I call the first string key informants. And these are the folks who are on the front lines of the epidemic. And that may include people who are in recovery, people who are in the recovery community, people who are not in recovery, people who serve people in recovery, people who serve in agencies that help to serve all of the related needs of people in recovery. So what I'm going to do during the presentation is there's going to be some slides where you'll see a quote. And those quotes come from our first string key informants. And what I'm going to offer, hello, and hello and hello. Hamina Lovelock and Krista Nordberg both work with me, and I'm glad they're here. And you missed my gratitude to Washtenaw County government. And one of the most remarkable interns I've ever had just walked in. So anyways, I'll be sharing with you some quotes from these key informants. And what I'd like to do is offer those as sort of a point to take a breath in the presentation so that I can stop talking and I can hear from you. The vast majority of the presentations that I do, my audience knows way more about the issue than I do. It's helpful for me to understand where things are in the community or in your expertise. So what I'd like to do when you see those quotes is feel free to shout out anything you like. We'll take 30, 60 seconds, not to have a full discussion, but just tell me what things you're thinking about and things that we might want to bring up at the end to have a discussion about. So I'm going to focus on most of these with the exception of the treatment admissions and arrests today. So what's the current reality regarding the opiate crisis in Washtenaw County? First of all, we have at least one opiate overdose for Washtenaw County residents every day. Now, all of my data is going to be focused on Washtenaw County residents. It's not occurrence-based. So even though somebody from Livingston County may be shipped in here to Michigan Medicine Hospital, they won't be counted in my data. It's just residents here. So one resident every day overdoses, and that's at least. And I'll tell you what how I define an overdose and how I calculate that. First of all, I look at emergency department admissions for opiate-related overdoses that are unintentional. Intentional overdoses, I put it in a different category. Unintentional overdoses. And then anybody who dies from an opiate-related overdose. I put those together, and that is my number for overdoses. There's a million ways to do this, and I can tell you I'm missing a lot, and I hear from people in the community there are overdoses that happen that we don't know about. I can only measure what I can measure at this point. I can tell you that if somebody makes it to the emergency department, it probably means that they received naloxone. It probably means that they will survive their overdose. And obviously people who expire don't make it to the ER. So for the most part, almost 99%, there's no overlap. So first of all, this is a map of Washtenaw County. It's not enormously clear, but right in the right-hand side there, Ann Arbor, Ypsilanti area. And these are the emergency department admissions for opiate-related overdoses between 2011 and 2016. So each of those dots represent one person overdosing. Those dots are distributed randomly in the zip codes because I don't want to violate any sort of confidentiality. Second thing you see is during that same time period, each of those dots represent someone who died from an opiate-related overdose. We put those together, that's what we're seeing. So during that time period, there were over 1,100 opiate-related overdoses. So I took this directly from my, it's called the Washtenaw Opiate Report. Washtenaw County Public Health Opiate Report. And what we do is we track both the deaths and the overdose admissions over time. You can see the red bar is the emergency department admissions and the deaths are the blue bars. So if you want to see on a monthly basis, we also have a mailing list if you'd like to be part of this publication. But you can see the general upward trend here. And you can also see that just since between January and July of 2017, already 200 overdoses. So these data are not as recent as I would like. These data come from the Michigan Department of Community Health, and they have like a 2-year lag on the data we get, which is why it's really great that the medical examiner shares data with us directly. But what I wanted to look at here is how mortality has changed for leading causes of death. And these are leading causes of death as listed by the Michigan Department of Community Health. So what I wanted to do was take a look at what's happened between the year 2000 and the year 2014. And what you can see here is at the top of the list, opiate-related overdoses have had a 1,525% increase compared to other deaths. For those of you who are interested, hypertensive, heart disease, falls, and Alzheimer's disease follow. We also have had a drop in the average age of death for those who have died related to overdoses, in particular for females. So for males, we've seen about a 4-year drop between 2010 and 2016, a 14-year drop for females. And there's a number of reasons why I think that might be. One of the folks who are in the recovery community shared with me that often what happens with a woman is she doesn't actually inject herself. Often it's someone else injecting her. That's part of it. Women weigh less. And I'm sure there's other issues. The number of Washtenaw County residents who died doubled between 2011 and 2016. We don't have many diseases that we could say that about. This is a map of case fatality. The way that I define case fatality is take the total number of overdoses as I defined them earlier, and or the total number of folks who died in a zip code, who were residents of that zip code, and divide it by the total number of overdoses to residents in that zip code. So we know that between 25 and 30% of the overdoses result in death. That's a very high case fatality rate. And you can see here the zip codes in darker blue and purple have the higher rates. And I think this is really interesting. I would not expect towards the Ann Arbor area a higher case fatality rate. So we have to wonder a few things. Are the drugs that they're getting stronger? Are the folks younger? Are they less likely to one of their friends or family members call? Are they more likely to die alone or use alone? And I suspect a lot of those are influencing these things. So regarding emergency department admissions, the number actually tripled between 2011 and 2016 for the emergency department admissions opiate-related overdoses. I also wanted to look at how many of those admissions are to people that they had more than one overdose. The only way I could really look at that is by medical record number, because I strip all other identifiers. So the only thing I can tell you is those folks were not admitted to the same hospital twice during that time period. Only 20% are repeat visits. So one of the issues that's come up in the media a lot and many discussions is the differences between overdose rates in African Americans and whites. And unfortunately, I cannot give you the mortality rate in Washtenaw County, the difference, because the medical examiner has only just recently started providing me with race data on mortality. I do have it for overdose admissions. And I can tell you the rate is very similar. Anecdotally from our local experience, the mortality rate is much lower for African Americans. I think one of the reasons why that mortality rate is lower is that African Americans who overdose from opiates are much older than whites. They may be more experienced. They may be using different kinds of drugs. They may be in a different kind of social setting when that overdose happens. So what are some of the forces that have probably contributed to this epidemic? First of all, and these are things that I really feel may have contributed, including things like the emphasis in the last couple decades to really reduce length of stay in hospitals. There's been a big emphasis on that regarding managed care. And for those of you who are young enough to remember, or old enough to remember, when you were in the hospital for an appendectomy or some kind of surgery, you were there for maybe a week or two until you didn't need narcotics anymore. And then you were released. But now people are in the community with narcotics. We also have seen a increase in the number of outpatient surgery. So we definitely have had this increase nationally in outpatient surgeries. Unfortunately, I couldn't get any local data for you. But clearly when somebody has surgery outpatient, they're much more likely to have narcotics out in the community as opposed to inpatient. Then also, obviously, increased opiate prescribing, and we could have a whole 8-month discussion on how that's happened. What this is the MAPS data, the automated prescription system, where I looked at zip codes, and I wanted to see are are prescribers changing their habits? Or what's changing? And so I wanted to look at between 2007 and 2015, has there been a decrease in the number of prescriptions by zip code? And zip code's really important in our county, in many counties, in that it really predicts a lot of the social determinants. So what I found was that in all of our zip codes, with the exception of one, there has been an increase in the number of Schedule 2 and 3 prescriptions filled during that time. So I'm going to take a breath. This is one of our key informants. Talked about how difficult it was to advocate for yourself. When you have an addiction, your doctor doesn't necessarily know you and is prescribing you addictive drugs. Anybody want to comment on the policy implications of that, the practice implications? Feel free. Just shout out.
What the date of this quote is from, because I would be more surprised to hear this in today as compared to even a couple of years ago, given the attention and prescriber education and.
I would tell you this is 3 weeks ago. 3 weeks ago.
3 years ago.
I'm a family physician and I'm surprised by that. I think there are still many physicians of all specialties that have inappropriate practicing or prescribing practices, and some of it is even out of a loss to know what else to do. We don't have good resources for helping people who have chronic pain or helping with addiction, and in a 15-minute office visit, it's very hard for people to address.
Right, there's lots of reasons this happens, but it happens. Thank you. Also, what's really interesting to me, despite the fact that this is something that we have really focused on, getting people personal health care providers, there's many more people now who identify a facility as their usual source of care as opposed to an individual. The individual relationship between a patient and a doctor is much more challenging now. And actually in Washtenaw County, and this is our health improvement plan survey I told you about, we actually have had a decrease in the proportion of people who say that they have a usual source of care. Now, I'm specifically looking here at people who have no health insurance, who have lots of other risk factors as associated with having no health insurance. But this is really challenging, because if our provider doesn't know us and we don't know our provider, it's a whole lot more difficult to deal with the subtleties of pain management and that sort of thing. So some people in recovery have an attitude change, or some people can be in recovery, have an attitude change even before they stop using. So this person was telling me the different definitions of what recovery is, and that there's not just one definition. And there was also the emphasis that unless the person is able to really change their circumstances, change their environment, think about yourself, living in a new neighborhood, a new house, all of your friends have to change, probably some of your family members. This is not an insignificant issue. Comments on this? Shout out. Okay.
I think we have to do a lot more on social determinants of health in this issue, and we're not putting enough money towards housing, employment, these other things.
Right. Did you all hear?
Can you repeat it? Repeat what you said.
Pardon?
Can you repeat what you said?
No? No, I had a little trouble hearing it. I think the room is reverse acoustics.
Just the There needs to be a greater emphasis on social
Thank you.
determinants of health in relation to the opioid epidemic, and putting funds they need to go towards treatment and primary prevention, but also towards housing, employment, all these social services that people need, or they're not going to get out of the situation.
We have a slogan in Washtenaw County, housing first, and absolutely has been shown to make everything better, and everything is worse if there's no housing, no stable housing. So other social determinants, work has changed. I was really surprised at this. This is a survey question again of Washtenaw County residents. I expected the number of manual labor, proportion of manual labor jobs to have gone down. Right, Dr. Richardson? I figured. Not the case. So in Washtenaw County, it's actually the people who say that their job is physically demanding, more physical labor, heavy labor, has actually increased in the last decade. We also, and you know, most of these things are true nationally. I'm focusing on local today. I would love to be able to compare with the state and the nation, but you have to invite me back for that. So also the proportion of people who are unable to work, who have any limitation, has gone up for Washtenaw County residents. So about 14% to about 20%. So these are people who say they have any limitation. It doesn't necessarily mean it's a serious limitation, but any limitation could be physical, mental, emotional, has gone up to 20% of Washtenaw County residents that fall into that category. We also know that people who, that we have an increased proportion of folks who are on disability who are under 65 years old. Furthermore, what some of the literature suggests is that around 40% of people on disability are either using opiates, have been prescribed opiates on a periodic basis, or are chronic users. So this seems pretty important. So treatment providers shared this with me. I'll give you a moment to take a look. So what's challenging about this is what many of our treatment providers have said is, we know that the opiate epidemic is really awful, but we still have the same people who had addictions before, people who have alcohol addictions and benzo addictions and all those other kind of things. Those people haven't gone away. They're still there. But because opiates are so lethal, they go to the front of the line. Any comments on the policies associated with this or implications? Okay. Also, there's been an increase in poverty. Again, you would not expect that in this county, but in fact, we have gone from 11% to 14% between 2000 and 2016. Everything is harder when you live under poverty. And I can tell you for sure, Washtenaw County is a terrible place to be poor. When you look at the housing costs here, other costs of living, to be poor here is much more taxing than somewhere else. So also, I think there's some health issues that have really impacted this epidemic, including things that are related to musculoskeletal issues as well as mental health. So we know for sure in our county that obesity and overweight has gone up in both youth as well as adults. 2005, for adults, 50% of us were overweight or obese. By 2015, 56% were overweight and overweight or obese. We all know that that puts a lot more burden on the joints, muscles, all kinds of other issues that work into a cascade of musculoskeletal issues. And pain, by the way. Also, hospitalizations associated with those musculoskeletal issues. And I'm sorry to frighten you with this, but I'm going to tell you what the whole point is. What I did was I lined up the leading causes of hospitalization for Washtenaw County residents. And these data are provided by the Michigan Department of Community Health. And then I wanted, again, to look at what's happened between 1998 and 2014 and the categories that of causes of hospitalizations. The categories that are in all caps are the summary categories, so you can even see where the summary categories fall. But what you see here is that the top 5, number 4 is osteoarthrosis and allied disorders, has increased 188% during that time period. I have to assume that there's pain associated with these conditions and that these folks are much more likely to require pain management of some sort. So, again, a very seasoned treatment provider shared this information with me. I asked, okay, so what do we do about this? What would you do if you had $10 million? Not a simple fix. But when I asked, I've heard that we have adequate care, access to care, and I've heard that we have inadequate access to care. This treatment provider said, we have adequate access to care in some cases, but it's not appropriate care. So a little bit more on musculoskeletal and mental. We've had an increase, and I could share lots of information that would demonstrate this, but we've had an increase in the number of folks needing mental health treatment. This is, again, another scary graphic, which basically these are emergency department admissions for people who are who are 18 years and younger, who had self-harm or suicide attempt admission. And this is male, female. The males are in the purple, and the yellow are in the female. The females are in yellow. So you can see between 2011 and this is July of 2017, the overall increase in the number of those admissions. And we've seen that bear out, unfortunately, in suicide completions as well. How does mental health affect opiate use? And what I've heard opiate users say is that the euphoria is like you found your purpose in life and if you add to that mental health challenges, you can certainly see why there's reinforcement for use. Anybody want to comment on this? Okay, so what else do I think is making this whole situation worse? I'm just full of good news. The good news is the presentation's almost over. So, IV drug use. The stigma, we usually don't want stigma, but in this case, it has actually reduced for injection drug use. 7% of our middle school students say that they have injected a drug ever recreationally. 7%. And I'll tell you what, I compared that number to a number of our neighboring counties. We're right in the ballpark for other counties. This is middle schoolers. So I really wanted to stick at 49 and younger because that seems like the current generation of opiate users, and you can see 6% for the young adults, 25 to 34. When we look closer at those folks who say they've ever used injection drugs, we know that they are much more likely to say that they never or rarely get the emotional or social support that they need. They're more likely to have 10 or more poor mental health days per month, and they're much more likely to ever be diagnosed with anxiety. And one of our addiction medicine doctors, John Hopper, really emphasizes how important this is with youth, that there's a lot of undiagnosed anxiety out there with youth, and how good an opiate would feel to a young person with anxiety. So interestingly, one of the paradoxes of this epidemic is that as we appropriately reduce prescription drugs available, we also are likely to increase the use of street drugs. So here we see a bar graph of looking at death certificates and those that have a prescription opiate identified on that death certificate in the toxicology. We got to 0 this year, 0. However, almost all of our deaths had a synthetic opioid involvement. And synthetics that are street drugs, and those include fentanyl, carfentanil, and other sort of concoctions that are made in laboratories that are absolutely remarkably powerful. And sort of the difference between driving a car 55 miles an hour down the highway versus a Learjet. It's just a whole different ballgame. So regarding the synthetics, fentanyl and carfentanil, we also know that the average age is much lower than those deaths that do not involve synthetics. And a lot of the issue is regarding younger people are getting their drugs from places, from people they don't know, they're less experienced, and it's a much dicier game with the younger folks. So this is representing our ambulance runs from the Huron Valley Ambulance. And what we see is that in 2010, that there was approximately 28% of the people between the age of 15 to 24 had no previously diagnosed mental health or substance use disorder when they had their overdose. In 2016, 67% had no previously diagnosed mental health or substance use disorders. In other words, youth are experimenting with opiates. So one of our outreach workers says, used to be 40 and 50-year-olds. Any comments? Feel free. Regarding women of childbearing age, we know that, that nearly half of the women who had unintentional overdoses were of childbearing age. 2014, we had 13 Washtenaw County residents born with neonatal abstinence syndrome. 2015, we had 23. We also have an equity issue going on behind the scenes as well, and that is that in zip codes that are poorer, more blue collar, those folks are being prescribed at a higher rate. So 48198 is Ypsilanti Township, 48189 is Whitmore Lake, has the highest rate compared to 48104, which is Central Ann Arbor, much lower rates. There's a lot of disincentives for asking for help. Dr. Marshall, thank you for coming. She and I attended a meeting with people who are in recovery, and they shared with us, she asked, why didn't you ask for help when you started to notice you had a problem? And these were some of the answers we got. These are pretty difficult issues to overcome, and the fear associated with them. This has really been interesting to me that people aren't actually concerned always about being identified as an addict, but really primary for them is, am I going to be a felon when I ask for help? So what are some of the things that we're doing in Washtenaw County? This is not an exhaustive list, and for those of you who are doing other things not on this list that I did not include, I apologize. But we're doing a lot. We're certainly not finished. Obviously, provider education is huge. Our law enforcement agencies have been absolutely magnificent. We have been trying to raise awareness. We have great leadership from the Washtenaw Health Initiative Opioid Project. So any of you want to get involved in any of these, I'm happy to share information about how to do that. So what do we need more of? We need more of a full spectrum of both sides of the equation. The one side of the equation, which is very, very appropriately distracting, which is how to keep people from dying when they overdose, getting people naloxone. But also the other side of the equation is how do we keep people from becoming addicted? And not just how to get somebody into treatment once they've been, have a dependence and addiction, but really the full spectrum, in addition to the environmental, economic, and policy solutions that we've talked about being part of the social determinants. But some of the things the tools that we have in our toolbox from numerous other public health issues over the last number of decades include street and neighborhood outreach, where the community is really the eyes and ears, has been used for many issues, successfully, very successfully. Issues like Ebola, issues like HIV, cholera, and even things like gang violence and gun violence, street and neighborhood outreach, and harm reduction. So important to understand the subtleties of recovery. So as we go out into our communities and try to understand what's going on, we have to be open-minded, I believe, about how we approach it. There's lots of different models for looking at issues that are this complicated. I think it's very important to get up close and personal. Working in small, defined areas, a county is too big. It must be neighborhood level. That's where you learn things. That's where you're able to talk to human beings. If policy researchers don't know community members' first names, there's great opportunity there. It's ongoing relationships, not just focus groups, but ongoing relationships. It's critical that those who are at the front of this epidemic trust people like us to share with us how things can improve and how we can contribute to that improvement, including researchers, government agencies, representatives, and of course community members. So I'm just going to close with another quote from Matt Davis that I think is right on spot. And that concludes our presentation. I apologize about the shameless promotion of researchers doing work and research in our community, but it's my hidden, not very hidden agenda. For the last 30 years, Washtenaw County really represents a perfect microcosm of much of what's going on in the United States. And I encourage you to consider doing some of your research with our local community. Okay. Thank you.
So we have some time for some questions. We have a lot of questions. Thanks for that presentation. I have lots of questions and lots of comments, but you've asked us to think about 20 years from now, what do we want to have learned from this epidemic? And in listening to you and in my own sort of clinical and health policy experience, I would say stigma makes an epidemic worse. And that's been true of HIV, of lots of different kinds of diseases that have been in epidemics. If it's stigmatized, if people are ashamed to tell anybody about it, it will make it worse. They won't seek help, they won't ask for help, therefore they probably won't get help.
Right, the young woman that said that asking for help results in punishment.
Oh, yeah.
As a couple of your slides showed really well, the shift towards using heroin and other synthetics rather than prescriptions. And a lot of the efforts right now are still based on like prescriber practicing and really cracking down on like the number of prescriptions that are out there. Do you think that that has the potential to make things worse before it makes it better? Because now we kind of, as healthcare providers, we open Pandora's box and get a lot of people addicted, and then when the prescriptions aren't there, then they might turn towards harder stuff.
That's one of the biggest paradoxes. And that's why I didn't provide a solution for it. This is complicated. I'd be happy to have somebody else comment on that, your opinions. Some of the clinicians, maybe?
I was just going to say that when we stop prescribing inappropriate regimens or do rapid tapers with people, and we don't give them other opportunities to either get help for their addiction or cope with their pain or mental health concerns in another way, then I think we are just turning them to, synthetic opioids. But I think maybe there needs to be more than just emphasizing prescribe less Schedule 2 and Schedule 3s and more holistic education and resources for docs on what to do as an alternative.
Thank you.
Wonderful presentation, Adrianne, as
Thank
always. I'm an internal medicine pediatric physician, and I remember in residency, and this may have been said before I came in the room, we were really pushed to assess pain well. It was the fifth vital sign, and to make sure that we were treating patients appropriately. And now many years later, I go to a lot of meetings regarding the opioid epidemic, and I don't think I'm sensitive, but sometimes I feel like there's a lot of physician bashing, and some of it is rightfully so, but it's, as you all said, it's so much more complicated than that. We have insurance companies that don't want to fund alternative treatments because opioids are cheap. So we have pharma, promoting opioids, and these are very powerful drugs, as you all know, that historically have been used for injuries like broken bones or pain associated with cancer. And now, over the last couple of decades, my back hurts, and here you are giving a ton of a very powerful opioids by prescription. And so, with that being said, I think, Adrianne, the data you're showing us and some things that we're seeing in the literature tells us that it's not just a provider-driven issue, because we see other things like the rise in suicides and other social problems that we see in residents locally and then just across the country. And so I'm being long-winded, I'm going to wrap this up. So I think that there's something deeper in the atmosphere, something that has been brewing over the last couple of decades about our society, and that this is a manifestation of that. Adrianne, I don't know if you presented data, correlating for data about the increase in eligibility for SNAP benefits or free lunch.
I shared about increase in poverty as well as disability.
Yeah. Right, and so I think that, you know, as the young lady back here previously said, getting at those social determinants of health and not just doing the tertiary prevention, which is important. The naloxone is so important, and harm reduction type of interventions, which be more on the secondary prevention level, so important. And I think we also need to pay attention to primary prevention and getting at trying to prevent people from even getting to wanting to use opioids, whether they're synthetic or not.
So I think that's really interesting comment, that there's something else going on that's underlying this whole thing. And I just wanted to put a plug in for a book that has one framework that I think is helpful that's come out recently. It's called The Hacking of the American Mind. I don't know if any of you have read it, but it's basically a neurobiological explanation that ties together addiction, obesity, and depression in a pretty interesting way, and it ties it to a cultural understanding of or lack of understanding or conflating of two concepts which neurobiologically are very distinct, and that is pleasure and happiness. And that's the pleasure driven by dopamine and the happiness driven by serotonin. And it's a fascinating book, and it ties together a lot of the things that we're seeing that may explain some of the underlying trends in our culture that have led us to have an addiction problem with opiates, and also to some degree an addiction problem with carbohydrates and other things.
Thank you.
To add a little bit to the previous comment about social determinants of health, I remember there was a slide in which I think you illustrated the changes in Schedule 2 and Schedule 3 prescription drugs by zip code. I was wondering if you've looked at which factors or which differences by zip code might be contributing to those things, because I can imagine certain zip codes maybe have like a different density of providers or different types of providers available, patients that have access to different types of coverage or maybe no coverage at all in terms of health insurance. And clearly it's going to be a multifactorial answer, but I was wondering if you've looked at that, or if you have any ideas about what might be the biggest contributing factors to those metrics, and specifically.
With my data, I can really only make loose associations, because the MAPS data that I get basically has a zip code of somebody's residence, what kind of drug that they filled a prescription for. So I can't actually do it with those data. We can make some guesses. Dr. Gould and I were talking about this, and she shared some really great insights about why those folks might get more prescriptions, including things like they are more potentially doing manual labor jobs. They're more likely to become injured on the job. They're less likely to be able to take sick days. They probably don't have as great of insurance, and if they do have insurance, it's probably not paying for things like acupuncture or other kinds of alternatives. They're probably having to work through the pain. They probably have less of a safety net beneath them, and so there's a whole, they can't really afford to take the break that someone else might be able to do who has more resources. So, but it sounds like a perfect research project.
So I'm a clinical research assistant here, so I'm not a clinician, don't have leverage over research direction or access to funding necessarily. So what would you say is the best thing someone like me could do if, because I'm both personally, because my life's been personally affected by this issue, as well as just intellectually interested in what's going on. What do you think the best thing that someone like me could do to get involved, locally or otherwise with this problem?
I think personally is probably the most time-consuming and difficult, but probably the biggest reward is spending time in the community, whatever that means for you, listening. And the community might mean people in the recovery community, but it could also mean people like Krista Norberg working in Washtenaw Health Plan, who works on the front lines working with people who have many of these challenges, or going to a DHHS office trying to understand. And that all sounds really weird, and how do I organize that, and how did I make that happen? It's really not that hard. And but I think listening is and getting into places where we don't necessarily have big data sets, but I'm coming from community, from government, so that would definitely be the hammer in my toolbox. But I hope you do whatever you can.
Adrianne, I think one of the things you've talked about in the past on our many walks has been, just to confess that we know each other well outside of work, is the role of adverse childhood experiences and how powerful those are as a predictor of both mental illness and chronic disease and addiction. I wonder if you could tell us a little bit about that, and what can we do about that? That's a very challenging.
Well, besides the $70 billion that the opiate-related industry is making from this epidemic, I think adverse childhood experiences are also really critical. And I say that because it's really tempting to focus on the individuals who are experiencing this issue, but also there's other forces as well. Madison Avenue is really powerful. So, but adverse childhood experiences, most of you have heard of that study, I'm assuming, but the likelihood that somebody with 4 or more adverse childhood experiences will have a suicide attempt is between 3,500 and 5,500 times higher than people who do not have those adverse childhood experiences. My understanding from talking to experts as well as the literature is one of the main things that we can do to prevent adverse childhood experiences is poverty prevention, as well as parenting training, working, and also people who have adverse childhood experiences are much more likely to bestow them upon their next generation. So that's about the best I'm going to do in a 20-second answer, but I think it's absolutely critical. All of these things work together. Yes?
I think we're out of time, so I'm going to call it quits for the questions and give you a break. We do have food out back, I think. Yeah, we have food out in the lobby, so we can mill around, eat food, and ask more questions out there. Okay?
Thank you so much.